Ladies and gentlemen, thank you for standing by. Welcome to the How State Health Agencies Can Use Community Health Assessments to Promote Health Equity webinar. During the presentation, all participants will be in a listen-only mode. Afterwards, we'll conduct a question and answer session. At that time, if you have a question, please press the 1 followed by the 4 on your telephone. If you would like to ask a question during the presentation, please use the chat feature located in the lower left corner of your screen. If you need to reach an operator at any time, please press *0. As a reminder, this conference is being recorded Tuesday, June 24, 2014. I would now like to turn the conference over to Fran Phillips. Please go ahead.
Good afternoon, everyone. My name is Fran Phillips. I am a consultant now working with the Association of State and Territorial Health Officials, known as ASTHO. I've had a long career in state and local public health and served as the Deputy Secretary for Public Health in Maryland's Department of Health and Mental Hygiene from 2008 to 2013. So I'd like to welcome you to today's webinar, How State Health Agencies Can Use Community Health Assessments to Promote Health Equity. In this webinar, we will describe strategies, resources, and tools used to promote equity throughout the community health assessment and improvement process, as well as describing examples of those processes and how they have initiated, facilitated, or supported efforts to promote equity in communities. As Albert indicated, if you have a question during the webinar, hold that question, and you're certainly welcome to post it to the chat box at the lower left corner of your screen at any time during the webinar. These questions will then be answered during the Q&A session at the end of today's presentation. We will also at that time open the phone lines if you would like to ask additional questions or if you'd like to pose your question verbally rather than through the chat box. At the conclusion of the webinar, you will be directed to an evaluation survey, and we really hope that you'll take a few minutes to complete this survey, as the feedback that you give us will really help inform future ASTHO webinars. So before we start the first presentation, we are going to include 2 polling questions in this webinar as a means and a manner to encourage active participation from our audience. So let me read you the first polling question, which should appear on your screen. Have you participated in a community health assessment? And if so, please indicate which kind. There are some options there: federal, state, local, accreditation, community benefits. Please check all that apply, including other, and we'll go to the next slide and read the results as soon as they are tabulated. So go ahead and give us your response to the first polling question if you like. Well, it looks like we've got a lot of participants. Well, the bars are still moving. A lot of participants have had, I would say, association with local community health assessments. Second, with state. And then it looks like accreditation, federal, community benefits are also fairly well represented, as well as that other category. So that clearly indicates, I would think, that we've got amongst respondents anyway, we've got a group of somewhat experienced audience members. That's terrific. So thank you for your involvement in that first polling question. We'll come to a second one in a moment. But first I want to take the opportunity to introduce our panel of esteemed speakers in the order that they will be talking with us this afternoon. Our first speaker is Gail Nelson. Gail is a senior policy analyst at the Hilltop Institute, which is located in the University of Maryland College Park campus. Gail is the director of Hilltop's Community Benefit Program, a central resource created specifically for state and local policymakers who seek to ensure that tax-exempt hospital community benefit activities are responsive to pressing community health needs. She is responsible for conducting research and analysis of issues related to community health benefits and the development of issue briefs and other resources and tools that can be used to promote more accessible, coordinated, and effective health systems. Before joining the Hilltop Institute, Ms. Nelson was in the Office of the Director at the National Institute on Minority Health and Health Disparities at the National Institutes of Health. Our second speaker is Kevin Barnett, a senior investigator with the Public Health Institute. For the past 20 years, Kevin has been engaged in research and fieldwork on hospital community benefit practices and health workforce development, with a focus on increasing diversity. Kevin has also worked closely with hospitals and health systems across the country on the advancement of community benefit practices and health workforce diversity. He has led 2 national studies examining diversity-related accreditation standards. Kevin currently serves as the co-director of the California Health Workforce Alliance and the advisory board of the Kaiser Permanente Institute for Culturally Competent Care. Our third speaker, Jeffrey Wilkinson, MSW, is Director of Policy and Planning at the Massachusetts Department of Public Health and teaches health politics and policy for the Boston University School of Public Health. As a member of the Department of Public Health senior management team, he oversaw the Office of Healthy Communities for 6 years and was closely involved in promoting community health needs assessment. Currently, he serves as principal investigator for a CDC-funded project that is developing regional health districts across the state of Massachusetts, each of which conducts CHNAs, Community Health Needs Assessments, for its combined population. He also oversees the Office of Health Equity and chairs the Massachusetts Board of Certification of Community Health Workers. Kevin will be leaving DPH next month, July 2014, to accept a full-time faculty appointment at the Boston University School of Social Work, where he will teach and practice community organizing, management, planning, and health policy. So I think you'll agree we have a really wonderful set of panelists to hear from this afternoon. But before we get started with Gail's presentation, we will have one more polling question. So if you can look on your screen, you should see community health assessments and implementation strategies can be used effectively as a tool to address health disparities. That's a second polling question. If you would go ahead and indicate whether you agree with that statement, disagree, or you don't know, and we'll take a minute, tabulate the results, and present them. Well, I will say that here in Maryland today is a primary day, as it is in many other states. I would say that this is definitely a landslide. Okay, there's a very strong sentiment amongst participants that these assessments and implementation strategies can in fact be used as a tool to address health disparities. So with that, I think that's a terrific segue to Gail's presentation. So I'll now turn it over to Gail Nelson from the Hilltop Institute. Gail?
Thank you, Fran, and good afternoon. As Fran said, I'm with the Hilltop Institute, which is at the University of Maryland, Baltimore County. We're a nonpartisan health research organization with an expertise in Medicaid and in improving publicly financed healthcare systems. We're dedicated to advancing the health and well-being of vulnerable populations. Hilltop conducts research, analysis, evaluations on behalf of government agencies, foundations, and nonprofit organizations at the national, state, and local levels. I direct Hilltop's Hospital Community Benefit Program, which is a resource for state and local policymakers. We conduct research, develop issue briefs, and provide other resources on the topic of hospital community benefit. Today, I'll be speaking with you about advancing health equity through the federal CHNA implementation strategy process. And I have to say I'm delighted by the poll results. We were a bit unsure as to the degree to which the audience would have actually participated in CHNA in the past, and so this is very, very good. And delighted that it sounds like a large percentage of the audience agrees that this process can be used to further health equity. Some state health agencies, although apparently not those in this audience, some state health agencies may not view federal community health needs assessments as vehicles they can use to advance state health policy. They may view them as vehicles that hospitals can use, but perhaps not so much that state health agencies can use. But the CHNA implementation strategy process can offer opportunities for state health agencies, in collaboration with nonprofit hospitals, to further key state health policies, including the focus of today's discussion, state policies designed to promote health equity. The term I've used, CHNA implementation strategy process, includes not just assessing health needs, but also prioritizing identified health needs, implementation strategy development, and evaluation. Slide, please. Now, what do I mean by health equity? I use one of the definitions employed by CDC, and that's this: when everyone has the opportunity to attain their full health potential, and no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstance. From the perspective of state health agencies, the connection between health equity and federal CHA implementation strategy process is this. Slide, please. The process can be used to address the social determinants of health, and addressing the social determinants of health is a primary approach to achieving health equity. You know, this audience is very familiar with what the social determinants are: poverty, education, employment, food insecurity, environment, language, culture, race, ethnicity. Slide, please. This slide just illustrates what you already know. It shows that while medical care, health behaviors, for some reason the little white diamond doesn't have a label there. It was supposed to say genetic factors. But in any event, it's very clear that the larger portion, the larger impact on population health comes from social, economic, and environmental factors. Effective initiatives executed through the CHNA implementation strategy process that address the social determinants will reduce health disparities and advance health equity. The first section of my remarks will address federal CHNA implementation strategy laws, policies, and rules. These apply to every federally tax-exempt hospital. Again, I remind you, when I use this phrase, CHNA implementation strategy process, I'm talking about more than just the CHNA itself. The phrase emphasizes that there's a continuum. It begins with the assessment of community health needs, but does not end there. Likewise, state health agency involvement in the CHNA implementation strategy process also starts with the CHNA, but it need not end there. Based on your responses to the polling question, it's clear that many of you have worked on federally required CHNA. There may be some that are not familiar with this process. That is understandable because the current federal standards are relatively new. Slide, please. My remarks are premised upon 4 basic propositions. 1, tax-exempt hospitals and state health agencies share a common interest in improving community health and in advancing health equity. 2, hospitals must follow the requirements of the federal rules and regulations. 3, one such requirement is that hospitals are mandated to take into account health agency input related to the assessment of community health needs. Slide, please. Further, the CHNA implementation strategy process affords state health agencies 3 additional junctures at which, within the context of a collaborative relationship with a hospital, state health agencies can influence the entire process so as to advance health equity. That said, I'll briefly provide background information on hospital community benefit, and then I'll talk about the overall process. Slide, please. The IRS declared in 1969, and many of you know this, that hospitals seeking exemption from federal taxation must provide benefits to their communities. IRS doesn't set a dollar amount that hospitals must expend, but tax-exempt hospitals must invest in the community benefit each year. And what are hospital community benefits? They are initiatives, activities, and investments undertaken by tax-exempt hospitals to improve health in the community they serve. According to one 2013 study, more than 85% of community benefit expenditures were devoted to charity care and other patient care services. We all know how vital those are. However, hospitals also devoted resources to community health improvement services, a category that can include housing improvement, community gardens, child care for low-income residents, mentoring programs, and other non-clinical matters. Slide, please. In 2010, the ACA specified new requirements for tax-exempt hospitals. The IRS fleshed out those requirements by proposed rules. Together, the new requirements comprise the CHNA implementation strategy process. This process offers 4 discrete opportunities that health agencies will want to utilize in order to advance health equity. Slide, please. I'm looking at the slides to make sure we're at the right place. Okay. Again, this process offers 4 discrete opportunities for state health agencies. The first one occurs during the assessment of community health needs. Second one occurs during the prioritization of identified needs. This is a key step because only needs that are deemed significant must be addressed. The third step is implementation strategy development. Implementation strategy is a written document that describes which significant needs will be addressed and how they will be addressed. The fourth step is plan for evaluation. I'll start with step 1, assessing community needs. ACA Section 9007 requires each tax-exempt hospital to conduct CHNA at least every 3 years. Slide, please. The IRS proposed rules that hospitals are operating under further require that every tax-exempt hospital must, during the assessment process, take into account input from, number 1, at least one state, local, tribal, or regional public health department, and 2, members of medically underserved, low-income, and minority populations. I'll repeat that because it's very important. Every tax-exempt hospital must take into account input from at least one public health agency when it is assessing community needs. Slide, please. This federal mandate gives state health agencies an opportunity to provide input related to broad social determinants, policy perspectives, specific health equity, health disparities policies that they'd like to see advanced, policy-relevant data, and assistance in identifying additional data if needed. State health agencies can also suggest reaching outside the health sector to enable stakeholders working in other sectors such as education, housing, and criminal justice to be involved. For example, if early child development programs are a state policy priority, then a state health agency can provide input related to that and seek inclusion of relevant data and relevant stakeholders during the assessment process. The same is true for other state health priorities such as healthcare access, community safety, injury and violence reduction, air and water quality. A community health needs assessment that includes data relevant to non-clinical health disparities and the social determinants is a necessary prerequisite to state health agencies' use of CHNA process to promote health equity. In addition, I suggest the requirement that hospitals seek health agency input during the assessment stage should be regarded as the opening of a door, an opportunity to solidify a broader hospital-state health agency collaborative effort towards community health improvement generally, and more specifically, towards advancing policies promoting health equity. Collaboration and community engagement are key themes evident throughout the ACA. Hopefully, in the spirit of the ACA as a whole, tax-exempt hospitals will welcome participation in all aspects of the CHNA implementation strategy process, and not just in connection with the assessment of community needs. From the perspective of state health agencies, collaborating with hospitals for community health assessment and health improvement planning can benefit a health department's efforts to attain accreditation. A CHNA conducted collaboratively by a hospital and a health department can address both the hospital's ACA responsibilities and Public Health Accreditation Board Domain 1 accreditation standards. Slide, please. After identifying community health needs, the rules require that the needs must be prioritized. It must be decided which needs are significant and which ones are not. This is an important step because hospitals are only required to address the needs designated as significant. In the context of a collaborative relationship with hospitals, state health agencies may be able to promote as being significant needs that are associated with the social determinants. Inclusion of some significant non-clinical needs in the CHNA furthers the opportunity to advance state health agency policies that promote health equity. The next stage in this federally mandated process calls for hospitals to develop an implementation strategy. This, as many of you know, is the hospital's written action plan. Slide, please. The implementation strategy must include, among other things, a description of the actions the hospital will take to address significant community needs and the action's anticipated impact. Notably, hospitals are not required to address every significant need. They must only explain why they will address some significant needs and not others. As with the earlier discussed steps, state health agencies seeking to advance health equity will want to ensure that the final implementation strategy contains initiatives and activities that address the social determinants that relate to the state's health equity goals. Slide, please. Evaluation. The final step should be evaluating the impact of the strategies and programs that were implemented. The importance of evaluating the effectiveness of health interventions is familiar to all state health agencies. Interestingly, the federal rules require that hospitals submit a plan for evaluating their programs. They do not require that the hospitals submit the results of an actual evaluation. State health agencies may want to address this. State health agencies may wish to collaborate with tax-exempt hospitals to see that initiatives designed to reduce health disparities are, in fact, evaluated. A demonstrated reduction in health disparities advances the goal of health equity. Now, I've devoted the bulk of my remarks to using the federal CHNA implementation strategy process because the federal rules, of course, apply to all 50 states. However, about 1/2 of the states exercise some state-level oversight over hospital community benefit. 10 states require that hospitals engage in a CHNA implementation-like CHNA implementation strategy-like process to obtain exemptions. For purposes of state processes, state governments are free to structure procedures that afford state health agencies concrete opportunities to promote state health policy goals, including health equity. State CHNA implementation strategy processes are not required to mirror federal processes. Slide, please. Hilltop Institute has developed an interactive online tool, the Community Benefit State Law Profiles. You're looking at the initial page there, and you'll also see the URL under the title. The state law profiles present a comprehensive analysis of each state's community benefit landscape as defined by its laws, regulations, and in some cases, state executive agencies. This slide shows what you will see when you open the state law profiles page. By using the profiles, one can identify which states require state-level CHNA. Let me demonstrate. Next slide, please. One of the interactive capabilities of our website is that it can sort according to different criteria. If you look across the top, the green headings across the columns are different aspects of ACA, Hospital Community Benefit Regulation. The black one in the center has been selected, and that one is the column that that is the one that has implementation strategies. So it has sorted in that black column out of all 50 states, only those states which do have such a state process. I can see, I'm sure that's too small for you to read, but I can see that those states are California, Illinois, Indiana, Maryland, New Hampshire, New York, Rhode Island, Texas, Vermont, and Washington State. You can also use the profiles to learn about community benefit regulations of a single state, say Maryland. Slide, please. Here you're looking at the first page of a multi-page analysis of Maryland's hospital community benefit laws. You can see at the bottom, at least I hope you can see it, it talks about Maryland's regulations for a community health needs assessment. Again, this is state-level regulation, not federal. Subsequent pages would deal with implementation strategy and other aspects of hospital community benefit regulation. In conclusion, some state health agencies may not realize it, but they can use federal CHNA implementation strategy process as a vehicle for advancing health equity goals. The federal process and possibly analogous state processes offer opportunities for state health agencies in collaboration with nonprofit hospitals to further state health policies, including state policies designed to promote health equity and reduce health disparities. Thank you. These last few slides, this talks about Hilltop's Hospital Community Benefit Program. Next slide tells about Hilltop Institute more broadly, and the URL for Hilltop Institute appears at the bottom. Next slide. The final slide is simply my contact information in case anyone has questions or would like to get in touch with Hilltop at a later point. Thank you very much.
Thank you, Gail. That was a terrific foundation for CHNAs and the further discussion. We'll turn now to Kevin Barnett from the Public Health Institute. Kevin?
Hi, thank you very much. Good afternoon, everyone. I am based at the Public Health Institute, which is a private nonprofit research technical assistance and training organization based in Oakland, California. What I'm going to talk with you about today is a study that we've conducted, a national study we've conducted with funding from the Centers for Disease Control and Prevention through a cooperative agreement with our partner organization, the National Network of Public Health Institutes. The purpose of the study and the report, which was recently released, is really twofold. One was to take an early look at the new set of community health needs assessments and implementation strategies that were being posted online by hospitals. The CHNAs are required to be posted in a visible way on hospitals' websites. the implementation strategies are not required for posting at this juncture of pending determination of final regulations. But we wanted to have a look at what we saw, looking at four particular areas, which I'll touch on momentarily. The other purpose of the study was to develop a tool that focuses on supporting local and regional accountability. All of the new data that is available offers an immense opportunity for a wide spectrum of stakeholders to look in a more in-depth way at a number of aspects of this work and how to really drive the kind of change we'd like to see. Next slide. So the impetus, and I'll note that these slides are relatively dense, and the intention was for the participants in this webinar to be able to take the slides away and use them as a resource. I'm not going to cover all of the material on them in the interest of leaving as much time as possible for dialogue. So particularly in the states where there have been assessments, we see some evidence of collaboration, but limited primarily to the assessment process, and often the areas of focus tend to be driven by institutional imperatives. Something I've been hearing for decades now from community stakeholders and continue to hear is that they're not sure how to engage hospitals, and they're skeptical about the assessments that are being conducted. So I've already commented on this issue of transparency, and clearly a theme that will emerge in the course of my comments is an interest in greater alignment. Next slide, please. Next slide, please. So we focused on four areas in this study: how communities defined, how community stakeholders are engaged, how priority setting processes and criteria are developed, and then how implementation strategies are focused, both in terms of content and geographic focus. In our selection process, we selected 15 regions as a focus, with a mix of large and small, urban, micropolitan, and rural, to try to get a representative sample in terms of demographics as well as locations around the country. But one common criteria that we had for each site is each site had to have one or more census tracts where there was a concentration, and we selected two metrics to serve as proxies for health disparities: the percentage of the population under the federal poverty line and the high school non-completion rate. So each one of these 15 regions had these areas of concentrated poverty and high school non-completion. Next slide, please. So in this issue of how community is defined, one of the dynamics and one of the challenges is that the language that is put out there by the IRS is, and clearly we find, is somewhat confusing to the hospitals. It says on one hand to use the service area. We know that service areas often could lead hospitals to define their duties in a way that would not include communities where disparities are concentrated. And this can get reinforced to the degree that hospitals may be located in areas that are not proximal to low-income communities, but still have charitable obligations to be fulfilled. It's a challenge also because about a third of our nonprofit hospitals across the country are critical access hospitals. They have limited resources, and we've found from a number of other efforts that many of these hospitals are conducting their own assessments rather than being a part of larger collaboratives. Similar challenges for many of our local health departments in smaller rural areas in terms of resources and links to other areas where there may be health facilities in other jurisdictions call for broader collaboration. Next slide. Community engagement is an important area. The IRS only asks hospitals to consider input from community stakeholders in the CHNA. It says nothing about any other aspects of the community health improvement process. Next slide. Next slide, please. Priority setting and implementation. We know that an experience has been that priority setting, we often spend a great amount of time doing our assessment and a very short period of time doing priority setting. And our experience in hospitals that have done this, and in some health departments as well, is that we often see a disconnect between the priorities that are selected and the assessment processes that came before them. Next slide, please. When we began this process, we used and built upon a set of principles that were defined by our colleagues at George Washington University, Sarah Rosenbaum and Maureen Burns, that laid out a set of 7 core principles that ought to guide our community health improvement processes, not just the assessments, but the larger effort. And what we wanted to do was to look at what, in this case, what hospitals are required to do on the compliance side of the equation, and what it might look like and how that can be distinguished from a more transformation approach. This is one of the challenges that many hospitals are confronting across the country, is that there tends to be a focus more on compliance rather than how, in the context of health reform, these assessments and planning processes can actually be an engine to drive the development of population health capacity in these organizations. There are important exceptions to that, but it remains one of the key challenges. But as you go down through each of these principles, there are descriptions of what one would describe as a more transformational approach versus a more limited compliance approach to all of these aspects in the community health improvement process. Next slide, please. You'll see in the last 3 set of principles, in fact, the IRS and generally speaking, regulatory agencies are silent on the issues of evidence-informed investments, of continuous quality improvement, and pooling and sharing of data. But these are key, absolutely central areas to how we begin to better align and improve the quality of our community health improvement processes going forward. Next slide. So in looking at these, the 2 metrics that I mentioned earlier were the basis for the development of what's called the Vulnerable Populations Footprint Tool that we developed in collaboration with the Center for Applied Research in Environmental Systems based at University of Missouri Columbia. You can get access to this tool at www.chna.org. In addition to these metrics, which are automatically uploaded and are in sliders to be able to adjust and focus on the census tracts where these issues are concentrated, we also have an element so we can identify census tracts that are at 100% above the top quintile of household income, so we can see the contrast. Then you can identify and locate the hospitals and the FQHCs in those areas and the jurisdictional boundaries. This provides a very quick and informative look at hospital location, where these issues are concentrated, and where we ought to be focusing our resources. Next slide, please. Just a few quick findings on this. In the 15 regions, we were able to get access to 44 community health needs assessments. Only 10 of those hospitals of the 44 identified these geographic concentrations of disparities in the CHNA in their region. We saw a significant decline in community member engagement after the assessment. Of course, that is very much in line with a compliance mentality, that's what we're told to do. We also see a significant lack of focus, of geographic focus, where disparities are concentrated once we look at the implementation strategies. To their credit, we found total of 27 implementation strategies that hospitals voluntarily posted on their sites as part of this process. And then in general, we saw a lack of alignment with other stakeholders and sectors who are doing the same kind of assessment processes. I should also note that we did look for and took a look at the CHNAs and CHIPs that we could access. In many cases, we could not access those. A little over half of the health departments or the local health departments were we able to find those documents, and or in some cases they were short summaries. Some of that could clearly be an issue of timing, which is one of the challenges that we have in looking at ways in which to align our efforts going forward. Next slide, please. This is a map that highlights, and what you don't see are geographic markers on it. The public report that we released just this last month was anonymized. The general theme here is we want to highlight what are some of the issues, challenges, and opportunities that was not the purpose of the report at this juncture to punish or point fingers at individual hospitals, but really to encourage an improvement approach. What you see on this map are two service areas. It's defined by a set of two systems, two small regional systems, each with a couple of hospitals. What you see in the dark tan are the areas in this urban area where the concentrations of people under the federal poverty line were, in this case, 40% or higher. And those are the census tracts. And then to the right, you see in green the census tracts where household income is 100% above the top quintile. And then you see where the hospitals are located. So when you see that two of the hospitals within this immediate urban area outlined in purple define their community in a way that included almost all of the areas of poverty. Other two hospitals within the same general area but closer to the green areas define their community and their assessment area in a way that largely circumvented and very closely circumvented the census tracts where there were concentrations of poverty. We don't know whether or not there was an explicit attempt to avoid this. Again, this goes back to some of the confusion about the guidance that is given currently by the IRS. But I'll come back to that later on. Next slide, please. So this sort of highlights what we found in terms of the hospitals that identify the disparities in geographic terms, and then what you see on the smaller pie to the right is that even those that did, only about half of those identified and had a specific focus of programs and activities in these areas. Next slide. We also had found that the majority of hospitals set priorities as an internal process, most often among the hospital leadership. We did see some good examples in the cases where it was more a collaborative process, but there are a wide array of issues that came up around priority setting that, in the interest of time, I won't be able to cover today. Next slide. Another issue that I will just note that we came across was that in many cases, the criteria listed by the hospitals were not of sufficient specificity to inform decision making. For example, if you indicated that your hospital's charitable mission guided your selection of priorities, that does not enable you to be able to select whether or not you're going to, for example, focus on obesity or violence prevention. So this is an issue and clearly speaks to the need for more education. Next slide. This highlights, when we looked at the CHNA, the priority setting process, and the implementation strategy, and you can see the dramatic fall off in terms of community engagement. Next slide. We also saw a very high emphasis on clinical care, on the priorities. Now, some hospitals had individual programs that focused more on the social determinants, and I will note that a significant proportion of those that identified fell into the health behaviors categories. These are all county health rankings categories that we drew upon. A significant proportion of those in the health behavior area were programs and activities that focused on the issue of obesity, which offers significant potential. Next slide, please. So in the overarching sense, one of the things that we observed and became increasingly clear in this process is that we have a lot of entities out there conducting community health assessments. In addition to local health departments and tax-exempt hospitals, you have often health impact assessments that are being ordered in an area. I don't have it on this slide, but you also have increasingly general plans and comprehensive plans being developed by municipalities, have important health elements to those. Community health centers are required to do assessments as part of their Section 330 application. United Ways, community action agencies are required to do assessments. And even financial institutions, as it relates to the fulfillment of their Community Reinvestment Act obligations, there are assessments which are currently retroactive rather than proactive, but look at the degree to which they have invested their resources in the same communities where we are calling for hospitals to direct their resources. Next slide. So the quick selection of the recommendations from the recommendations offered in based upon the study findings. Clearly there's a need to better harmonize the array of not only the assessments but the larger community health improvement practices. Secondly is looking at, and these tools are intended to provide the information for a variety of stakeholders to ask the question, why are we not focusing our resources more in the specific communities where health inequities are concentrated? The tools are intended to support a quality improvement approach and to get people out of the frame of just thinking about compliance. And there clearly is a need to better clarify the roles of stakeholders in all of these processes, to both to support and validate the commitments that those that are engaged are making, as well as to identify who else ought to be at the table. Next slide. So we're currently doing a follow-up to the initial study. We're following up with a portion of the review sites to validate findings and provide supplemented with explanatory information. And we're getting some fascinating findings. We're learning things. And in addition to following up with the hospitals, we are following up with the other entities that I identified in the last slide, looking for opportunities for alignment and determining the degree to which those entities were engaged. And if not, what is the interest in being engaged going forward? We'll be releasing a brief with the findings from this follow-up within the next couple of months. We are also coming back to our second objective of doing this study, engaging a sample stakeholders group to pilot a user's guide that was developed and a set of online tools to look at, to support their efforts to look at hospitals and other stakeholders in their areas and the degree to which they are addressing these issues. Part of our work will also be to identify potential online homes for the user's guide in these tools. You'll see at the bottom is the larger report is available. There's the link to be able to access that. And the last slide, I would like to offer a few recommendations of potential roles for state agencies. One of the things that is available, it's more available in a number of states, such as Maryland, California, than others, but there's a clear need for it, is to find ways to provide the kind of data that would help inform more focused efforts in local communities. In both California and Maryland, there are the state has access to all hospital utilization data. So there's the ability to GIS code these data by payer source, by institution, and to in particular draw out the prevention quality indicators to be able to identify the high utilization that many hospitals are having for conditions that clearly could have been prevented. Making those available public would be an important driver. The second is looking at ways in which we can set broad goals that still allow for more unique approaches that make optimal use of local dynamics and characteristics, and look at ways in which to incentivize this kind of alignment. In a number of states, we did identify where the state agencies had played a role, particularly for critical access hospitals and local health departments in rural areas, to support more regional collaboration. We think more of that is needed given the significant number of rural areas we have across the country. It's also important to look at ways in which we can walk our talk in the public sector. What are ways in which the Health and Human Services agencies can better link with other sector agencies that have an interest in improving health as well as in addressing the social determinants of health in local communities. And last but not least is to really make sure that we're not just focusing on the assessment processes. We've had too much of a check-the-box mentality in this arena. There's really a need to focus on how do we follow through and how do we encourage that. With that, I will turn it back over to our moderator.
Thank you, Kevin. That was a tremendous set of amount of material and slides. Thank you for that presentation. I will say two points quickly here. Yes, the slides will be posted. I've gotten a couple of inquiries as to whether or not the slides will be posted, and we'll talk about that at the conclusion of the webinar. But no need to scribble down the URLs. We'll definitely put those slides up available. And secondly, I just want to encourage you again to go ahead and post your questions. Some really good questions are coming in, so don't hold back. And that would be in the chat box on the left-hand side of your screen. So now we'll turn it over to Jeff Wilkinson, Director for Policy and Planning in Massachusetts, the Office of the Commissioner. Jeff?
Thank you very much. Good afternoon, everybody. Almost good evening. My role is to explain how one state is implementing some of these principles and actually doing and promoting community health assessment, and particularly to address health disparities and promote health equity. So I'm going to, and can we get the slides aligned here? Great, thank you. I'm going to first talk briefly about a public authority for community health assessment in Massachusetts, because we're unusual among states in having two principal methods for doing this. Also talk about a broader approach to promoting community health assessment than community benefits that all state health departments have access to. I'll give you some examples of some special initiatives we're using in Massachusetts. I'll talk about our community health assessments in determination of need, and then also give you an example of a particular community's health assessment that I think addresses some of these issues helpfully. I just want to note that we have a population of just shy of 6.5 million people. We are number 44 in the country for land area, number 13 in population, and number 1 in terms of decentralization of our health department. So the organization of local public health and its relationship to the state health agency matters in these issues. Next slide, please. I mentioned we have two major vehicles. Community benefits are actually overseen by our state attorney general. And in Massachusetts, technically it's a voluntary set of guidelines to which hospitals are required to comply, and that gives you the mix right there. It's technically volunteer, but practically compulsory. The amounts that hospitals make available through their community benefits programs vary quite a bit, but they can amount to tens of millions or hundreds of millions of dollars a year for large teaching institutions. So it's a very important set of resources to be looking at. In Massachusetts, we also require institutions that make large capital expenditures to add new facilities, construction of new facilities, purchasing expensive diagnostic equipment, even including ambulatory care clinics to go through a determination of need process that dates back to the early 70s and which requires approval by our Public Health Council. It's similar to a state board of health. And so this is a mandatory regulated program, and applicants are required to develop plans to invest at least 5% of the maximum capital expenditure for their projects in community health initiatives to address the needs of vulnerable populations. So that's a very important source of resources in Massachusetts as well. Next slide. You have the next slide, please. Thanks. So there are there's a need to coordinate the work of the state attorney general, if applicable in your state, with the health department, and looking at those IRS requirements that Gail talked about earlier. And let's talk about some additional ways that state health departments can promote community health assessment. First, by providing the data that entities, including hospitals, depend on for doing their assessments. Our health department is organized into 9 bureaus, major departments, and a number of them promote community health assessment in their use of federal grants and state accounts for specific disease interventions and prevention activities. I'll talk about a few examples of that. We also have some strategic initiatives that I'm going to talk briefly about, including our signature effort at promoting healthy weight, a chronic disease prevention project that we're working on, and a couple of others, and then this determination of need project that I mentioned. Next slide, please. Data is a critical way that state health departments can support community health assessment. Here in Massachusetts, we have something called MassCHIP. It's a online integration of 39 separate state databases, including the Behavioral Risk Factor Survey, the Youth Risk Behavior Survey, census data. I've listed some of them on the slide, but literally over 36 databases. Those are organized variously. We allow power users to do deep dives into research, but we also post dozens of so-called instant topic reports. And so it's an important way that health departments can make data available so that local health authorities and hospitals and other users can have ready access to the data to make assessment possible. We have one of the CDC environmental health tracking pilot grants in Massachusetts that allows GIS mapping and involves some overlap and some different databases for as MassCHIP. And we are now integrating all payer claims data with public health data in a major data warehouses. We're kind of taking a new approach over the next couple of years to organize and make data available. And I know a number of states are looking at use and reporting and sharing of data. So I think it's important to understand its value in promoting community health assessment. Next slide, please. I mentioned we have a number of bureaus, so just a few examples. Sometimes as a condition of federal funding, and sometimes because of the approach that our leadership and staff take, we end up requiring applicants for contracts to do community health assessment or assessments on specific diseases and conditions. So we have a state integration plan for chronic disease that was funded through one of the CDC competitive integration grants. Our maternal and child health block grant took a very progressive approach to community health assessment in combination with partners. Lots of work in HIV/AIDS prevention along these lines, substance abuse, emergency preparedness as well. We've done a lot of work with partners assessing the needs of vulnerable populations and coming up with plans for addressing their needs. And let's look at the next slide. Next slide, please. Thanks. We just skipped one. There should be a slide that before that called strategic initiatives. Did we just go over the? I think we skipped a slide. Okay, I'm not getting much. There we go. Thank you. So I want to talk about several strategic initiatives at the department briefly. One is our Healthy Weight initiative called Mass in Motion. We started this with a public-private partnership with philanthropies, but we ended up using community transformation grant funding, and we are working with 52 cities and towns now, a third of the state's population, in efforts to address the built environment and social determinants of health, and we're looking at disparities reduction in these efforts. So community health improvement and community health assessment was integrated in each of these local partnerships. Next slide. Next slide, please. Again, we've skipped one there. Looks like a touchy switch. Can we go back to the Prevention and Wellness Trust slide? Okay, thank you. The Massachusetts legislature incorporated into 2012 healthcare reform law, state healthcare reform law, the nation's first major investment in public health prevention at the state level, a $60 million fund over 4 years to promote prevention of chronic disease and other conditions that could show return on investment in that period. In January of this year, we announced 9 partnerships totaling just over $40 million. So we have these community provider partnerships addressing the areas that are shown on the slide. These are efforts that are connecting primary care and community prevention. They all include policy initiatives. They're looking at the built environment. They're looking at other social determinants of health. We also linked in our State Innovation Model grant that's pioneering an e-prescribing system. I won't go into detail there, but it allows providers and community-based prevention programs to refer back and forth through an electronic system. Community health assessment and improvement planning was required in the planning grant and RFR for all of this. So the point is that in all sorts of different ways, state health departments can use the resources at their disposal to promote and require partners to do health assessment. Let's look at the next slide, Office of Health Equity. Our State Health Office of Equity, Health Equity, next slide please. Next slide please. Again, we've skipped one. Back to the Office of Health Equity. Our Office of Health Equity is pulled together 58 individuals representing 32 individuals. We're not on the right slide, but I'm just going to tell you about this briefly, and then we'll just leave the slide where it is since we seem to be having trouble. If you can find that Office of Health Equity slide, it'd be great. The University of Massachusetts Medical School has been consulting. We used CDC funding for this, and again used a comprehensive community health assessment, needs assessment process with a wide array of advocacy groups, self-advocates, parents, providers, state agencies, academics, all to develop an assessment of the needs of people with disabilities. And there was a specific look at disparate needs of people with disabilities from racial and ethnic minorities and planning along those lines. Next slide. The National Public Health Improvement Initiative. Next slide, please. Oh, this is pretty frustrating. We're supposed to be on the National Public Health Improvement Initiative slide. I'm not sure what's going on, folks. But anyway, we are one of 14 states that received competitive funding from the National Public Health Improvement Initiative. And we are developing a set of 5 regional public health districts across the state that are getting cities and towns to share staff and services. There are 58 cities and towns included. 12% of the state population are involved in those 5 districts. All of them are required as a condition of funding to complete community health assessments for their combined populations of their districts. And we contracted with the National Network of Public Health Institute affiliate in Massachusetts for technical assistance on these on these community health assessments, and they are looking at health equity among the priorities. We're also using National Public Health Improvement Initiative funds to promote accreditation, and that includes a state health assessment and state health improvement planning. And again, most states are using NIFI funds to do that. It's another great opportunity to promote this work. Can we have the slide that says DON Community Health Initiatives, please? There we go. Back on track. So I mentioned earlier that we have the regulatory regimen that requires major institutions that are doing construction to do community health initiatives. We require that they collaborate with community health partners in determining, in conducting assessments, and importantly, and this is picking up on an issue that Kevin mentioned earlier, in developing the investment plans for how that money will be used. The amounts vary depending on the amount of construction and the cost of the overall project, but typically these are paid over 5 years. They can be as many as 7 years, and they usually amount to a few $1 million depending on the size of the construction. We specifically require that they address health equity in their plans. That's one of the main objectives. They're encouraged to consider investing in community organizing, policy change, environmental strategies for change to address social determinants of health. And so these are comprehensive scopes of service. There have been over a dozen of them completed in the past 5 years. And they typically use community health networks. It's the same acronym, unfortunately, as community health needs assessment, but these are community health network areas. We have this regional system of multi-stakeholder partnerships, health coalitions, but we also use other community-based health coalitions. And they develop their assessments and investment plans through collaborative processes. So you can promote the same approach using community benefits dollars in partnership with hospitals, even if you don't have a determination of need program. Next slide. One of our communities, the second largest city actually in New England, Worcester, Massachusetts, in the central part of the state, has used community health assessment very effectively. And I'll end with a little bit of a description of this one because it bridges both our community health needs assessment process through DON and through the Public Health District Incentive Grant Program I mentioned that we used NIFI funds for. Worcester is one of the 2 local cities and towns in the state that has publicly declared they're going to get Public Health Accreditation Board accreditation. They got funding from a local healthcare conversion foundation in the amount of $62,000 to support their community health assessment. They hired as a consultant an organization called Health Resources in Action. It's a Boston-based national consulting firm that's affiliated with the National Networks of Public Health Institutes. And so they've got a lot of experience in community health assessment, community health improvement planning, and also the state equivalents. They do preparation for accreditation for states. Working with Massachusetts, they also worked with Connecticut. And they used quite a broad partnership in Worcester, including their CHNA, or this community health network area that has all sorts of different stakeholders, public and private, businesses, community health providers, advocacy agencies, community-based social service providers, faith communities, etc. And they also worked with their United Way, with hospitals, and with their local foundations to develop the health assessment. They did. They looked at the data and they ran focus groups and they had key informant interviews, some of the methods that are normally done. They also ran a series of town hall meetings that didn't work very well, according to their health director. They basically failed at that, and he advises that don't even bother with that approach. This was done in the summer and it wasn't particularly effective, but he says you really have to take assessment to the people. And so what they did instead was very innovative. They used community cultural festivals in the Southeast Asian, African American, Latino communities. Since this is one of our districts, they have partnerships with nearly a dozen other cities and towns, and they took advantage of regional summer concerts that people were having, music concerts and others. They set up tables at each of these over 24 cultural festivals that they attended. They used a staff members, but also a dozen college interns. And they had roving interviews in the crowd with people. So they really took it to the people. As a result of all that data collection, next slide please, they identified 5 domains for their health assessment. And they were unusual in the experience of the National Network Public Health Institute consultant in that they decided to identify health equity as a specific domain. A lot of health assessments consider health equity and health disparities kind of in a cross-cutting way over everything, but they felt it was so important to their community that they named it as its own domain, and they set 4 health equity objectives, each with strategies in their community health assessment and the accompanying health improvement plan. So they are looking explicitly at addressing institutional racism, grassroots leadership training, policies, promoting policies to mitigate health disparities, looking at the social determinants of health, and then making sure that health disparities are addressed in all the other domains, including healthy eating, active living, behavioral health, violence and injury, and access to various preventive and clinical services. So in all sorts of different ways, state health departments can promote community health assessment and health improvement planning. Sorry for the confusion with the slides there, but if we can go to the final one, I'm listing contact information for my colleagues at the department. And as Fran noted at the top of the webinar, I will be leaving the department shortly to move to the faculty of Boston University. You can contact me if you're interested at gww@bu.edu. And my colleagues listed can help you with other areas that I've discussed. Thank you very much.
Well, thank you, Jeff, and everyone, all of our presenters, for your very insightful presentations, really packed with information. So at this point, we will start the discussion portion of the webinar. I have several questions and more coming in the chat room, and I believe, Albert, if you're on the line, that we have an opportunity for participants to call in with questions. Is that right?
Very exactly. So ladies and gentlemen, if you'd like to register for a question, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. If your question has been answered and you'd like to withdraw registration, please press the 1 followed by the 3. If you'd like to ask a question via the chat, please use the chat feature located in the lower left corner of your screen.
So with that, I'll give perhaps some time for those calls to come in, unless you have a queue already started there, Albert, or I can go ahead with the chat room questions.
Yes, please go ahead with the chat questions.
All right. Well, the first question I believe is probably directed to Kevin, although certainly any of the presenters could answer. The question is, can you comment on the relationship of hospitals to area FQHCs in conducting a CHNA?
Well, there are some important examples where there is work together, but I would say for the most part, there's not there's not a lot of history of collaboration. In some areas, there's even somewhat of a competitive dynamic because the clinics are for cost-based reimbursement reasons are seeking out and wanting to enroll Medicaid patients. And there is a perception among hospitals sometimes that, and sometimes maybe more legitimate than others, that the clinics are more inclined to want to serve the Medicaid populations than the uninsured patients that come into the EDs. I don't think anybody's done a study to validate that, but nevertheless, those are dynamics that are in play. In the context of the ACA, in the context of moving away from the perverse incentives we have now with the fee-for-service system of filling beds and conducting procedures to actually keeping people healthy and out of the hospitals, there's a new, it's a growing awareness, I would say, among hospitals that they can and need to work more closely with community health centers. We did a study this last year in California looking at clinics and the engagement of community health workers. And very few of them could, while they knew that the community health workers were having a positive impact upon costs, they could not validate that because in most cases they either lacked the analytic capacity or they lacked access to the hospital utilization data. So that for a host of reasons there is justification for these entities to begin working together. Sometimes it's a matter of overcoming just historical personality dynamics between specific individuals.
I would add, this is Jeff, I would add that in Massachusetts we're having somewhat of a different experience. So we have community health centers and hospitals collaborating in needs assessments, that especially the ones that are conducted through our Determination of Need program in cooperation with the community health network areas. Again, these are community-based coalitions that are multi-stakeholders. And I know Maryland has a regional network of community health planning entities. I would guess that would provide an opportunity for a similar kind of collaboration. We haven't, any of us, talked about power between the community participants and the hospitals in raw terms. But in fact, our experience is that community health assessments are a ground where the power between community coalitions and community providers and hospitals are coming into play. And we've had some very high-quality providers be surprisingly candid about their interest in managing the geographic areas and the issues that they want to look at in their community health assessment processes because, as Gail said, they're required to come up with investment plans for what they identify. And so they may know up front what they think they want to work on or with whom or where. And you know, there's going to be some advocacy necessary in some cases to bring the right parties to the table. But the IRS guidelines are useful that way. And if community partners are encouraged and supported by health agencies to do this, I think we'll see more of that kind of collaboration Kevin's talking about.
This is Gail. I just wanted to add that I agree with that. As I pointed out in my remarks, there are at least on paper rules that say that community engagement, both from the public health agency perspective and from the minority underserved community perspective, is the hospitals are required to take input from them. It isn't quite clear what they are to do once they have taken that input, but at least they are required to seek it out and to hear it. And I think that the more that happens in actuality will begin to improve the process and start to address some of the power issues, Jeff, you were mentioning.
Great, thank you. Albert, do you have a caller with a question, or shall I proceed here in the chat box?
No questions on the audio side so far, but ladies and gentlemen, it's the 1-4 on your keypad if you have a question.
Okay, let's roll into the next one. This is a question with a little bit of attitude, so I'm going to read it to you verbatim, and it's really open for the panel. The question reads as follows. What agency is responsible for monitoring the CHNAs and the charitable hospitals that are seeking input from stakeholders and communities experiencing disparities? Are there penalties for noncompliance? This is a particularly important issue as more of our charitable hospitals are moving their facilities to, quote, greener pastures where marginally incomed people do not live. Anybody want to take a crack at that?
I'll start with that. What you've raised is a very good question. At present, the entity that is governing this whole process is the IRS. And the IRS has issued and will be continuing, presumably, to issue rules, but it is not the kind of oversight that the questionnaire is asking about, a more active kind of oversight, isn't necessarily something the IRS has taken on in the past. Now, by statute, the IRS has been required to review 1/3 of the hospitals, of the nonprofit hospitals' community benefit plans each year for the past, I think we're in the 3rd year now. So they are at least looking at them, but they are not, they are looking at them as an information gathering tool to educate themselves as we understand it. And I don't think anyone would say that there is very close monitoring from the federal perspective.
Amen to that. I mentioned that in Massachusetts, the Attorney General oversees the community benefits guidelines, and that not only covers acute care hospitals, but also health maintenance organizations, separate sets of guidelines. That came about in the early 90s after a major university school of public health published what amounted to exposés about the assets of major nonprofit teaching institutions. And it was shocking how much money they were holding on to. And it raised a lot of community furor about whether they were in fact acting like nonprofits. And so I think to shake loose the resources in a community responsive way in some states, there will have to be that kind of partnership with academia or other researchers, or just good old-fashioned community organizing and advocacy with savvy health partners who know the federal law and are willing to challenge institutions to live up to their nonprofit obligations.
Just to build on that comment, it's not clear to me whether or not within the IRS there is either the capacity or the competencies to do the kind of analyses that are needed, particularly looking more broadly at some of the population health issues. Mm-hmm. And so our thinking and orientation and the focus of our study, the product is doing what was just described, which is providing the tools that support a variety of stakeholders to begin to do that initial drill down. There's some very basic and probing questions that can and should be asked around these issues to help drive them at the local level. And you can start by engaging the institutions, and if you're not getting sufficient response and focused response, then appropriately it's one could bring it to a variety of other elected officials and other public officials at the local level to elevate.
And I would just say that state health departments have a lot of power potentially in this regard if they're able and willing to exercise it politically within their own administrations, because they're often the regulatory bodies for these care providers. Mm-hmm. And you don't have to use a very heavy hand. Just some well-placed questions, some support of well-placed advocates and community-based providers can get those balls rolling.
If I can add just one more thing, the Hilltop Institute, in I guess our most recent issue brief, looked at the 10 states that I mentioned that do regulate hospitals' community benefit and regulate community health improvement services more directly. And what we tried to characterize in that, and we looked at over 500 implementation strategies, excuse me, from the different states, tried to characterize, at least in the legal and regulatory sense, what characteristics we seem to see associated, that were associated with the ability to scrutinize the CHNA process. And I would refer people, our website is listed on my slide, I refer people to that most recent issue brief.
Well, thank you. We have quite a few more chat room questions that I am certain we're not going to get a chance to get to. Albert, is anyone on the phone there?
No audio questions.
All right, so what I'd like to do is combine two questions for our final question and reassure people in the audience who have submitted questions that we will get your questions that were not addressed. We will get them presented to the presenters and addressed when we post the proceedings of this webinar, which I'll mention in a minute. But let me come back to, we've talked about politics, we've talked about the law and power. I want to circle back and make the connection again between community health needs assessments and health disparities. And particularly, I think the examples, Jeff, that you used of Worcester, Massachusetts, calling out health equity in its CHNA as a priority, and then a sub-strategy of that being to tackle the objective of eliminating institutional racism, is one that there is a question for some more details about that. Also a question about how health disparities figured in Massachusetts State Innovation Model Plan. So, Jeff, if you could talk a bit about that, and then we'll wrap up very lively webinar. Thanks, Jeff.
Yes, and I would refer people to the Boston Public Health Commission, which has its own website. It's the City of Boston Health Department, and their executive director, Dr. Barbara Ferrer, is a national leader in addressing health equity and social determinants of health, and has made it a specific objective to address institutional racism there and in their contracting and other work. And they have a whole department and an initiative that I think could be a useful resource for folks. Worcester similarly is looking at the need to address institutional racism in multiple forms. And I think it's interesting to me that this is becoming I wouldn't call it mainstream yet, but it's becoming less unusual for institutions that are looking at health equity and health disparities to call on partners to look at and address institutional racism specifically, because when we look at infant mortality, for instance, and other disparities, it's become clear in the emerging science that there are just too many anomalies to wish it away or come up with other explanations. The stress associated with prolonged institutional racism is all the plausible explanation for some of the disparities that we see, even across income and educational levels, especially with African American versus white infant mortality. So it's becoming a science-driven discussion increasingly. There are various curricula and strategies that health departments are looking at and promoting, so I'd say it's an emerging field, and Worcester is figuring out what that is going to mean for them specifically.
Great, thank you, Jeff. Those are just great recommendations for more information and kind of perspective. So I'm mindful of the time, and it's my job now to wrap up. I want to thank you all, presenters and participants, for joining us today. It's just a tremendously lively and provocative topic. As was mentioned earlier, you will be immediately directed to an evaluation at the conclusion of this webinar. So please, if you could take a few minutes to complete the survey, as it does give us some really important information going forward. I do want to thank the Centers for Disease Control and Prevention for sponsoring this webinar, and also to our speakers for their absolutely wonderful and tremendously informative presentations. I also want to acknowledge the staff at ASTHO, whose reliably high-quality research and background really supports these webinars. A recording of today's webinar, as well as the slides, will be available on the ASTHO website within the next few days. And the web address is on your screen now, and there's Nina's contact information, Nina being the wonderful staffer at ASTHO who worked so hard to put this webinar together. We will also include a summary of the questions that were not addressed and presenters' responses for those of you that did submit some really terrific questions. So we hope that you will use this webinar as a resource and go ahead and share the link with others once it's available. Thank you all. I hope you enjoyed this discussion as much as I did, and go ahead and enjoy the rest of your day. Thank you.
Ladies and gentlemen, that does conclude the webinar for today. Thank you for your participation. Have a great day.